I'm going to call up Kelvin, who is our
All-rounder.
next adversary.
Right, thanks, Andrew. So I'm going to show 3 cases. All 3 of them are PCV patients, and I find that more and more in my practice, I'm seeing much more PCV patients. And I got access to 8 milligram a little bit earlier than Andrew did, so probably about June of last year. So my first case, treatment-naive patient with PCV, and here you can see it's patient's ICG is a cluster of polyps, and I've put OCT cuts through the polyps. You can see the classic peaked PEDs with ring sign there, vision of 618, very, very classical looking PCV patient. And so treat with 8 milligrams. So I'm going to show you a series of OCTs after every 4 weeks with 8 milligrams. So at week 4 after the first injection, you can really see that PED and disease activity going away right through each of the cuts, vision improving. After the second injection there, you can see the flattening of those PED. I would argue that at this point, probably the polyps are already closed. And then again at week 12, you can see further improvement of the anatomy. And we've got ICG again at week 12, really proving that polyps closed after 3 injections of 8 milligrams in this particular patient. So very nice drug to use for polypoidal closure. Now, I'm quite obsessed with polyp lesion closure because I feel like with persistent polyp lesions, you run the risk of having submacular hemorrhage at some point, especially with extended intervals. So I really tend to chase down my polyps, and I do ICG to prove that things have closed. So in this particular case, really nice, classic PCV patient, diagnosed on ICG, and after 3 treatments, both disease activity and polypoidal lesion closure is achieved. Now, next case, again, similar to what Andrew was showing, and this is something that we probably will start in clinical practice. When you first get your hands on a new drug, you want to try it in patients that are probably the most difficult to treat. And so there'll be a lot of switch. Likewise, I did have some switch patients as well in my experience. So this was a case treated with Aflibercept 2 milligram in the beginning. So that's, again, baseline imaging. ICG, you see the polypoidal lesion, some subretinal fluid. And after 3 loading doses, you see post-loading with 2 milligram, absence of polypoidal lesion, and on OCT, again, marked reduction in disease activity. So I was like, this is great, fantastic. This is a great point to start extension. So I extended this patient up to 8 weeks, being a little bit bold. So it's 4-week extension on 2 milligram. And what you can see here is a resurgence of the polypoidal lesion now at a different point. So remember, the first baseline polyp was a little bit more superior, nasal, and now you get a new cluster of polyps, a little bit more inferior. You've got some subretinal fluid. So new polyps coming up with an extended 8-week with 2 milligrams. So at this point, I could have intensified the treatment with 2 milligrams, gone back to 4 weeks, but patient really wasn't keen on shortening the intervals, and this is in practice. Patients don't want to come back every month, at which point I got my hands on some 8 milligram. So here, after an 8 milligram and 8-week interval, so patient, remember, didn't want to come back 4 weeks after the injection. With an 8-week interval, I got the best of both worlds. I got an extension, and I've got anatomical improvement as well. And that's the ICG after 8 weeks, 8 milligrams. Again, absence of those polypoidal lesions. So best of both worlds, both disease activity control as well as polypoidal lesion closure. So fortuitous, not something that I would have done. I would have wanted to see the patient at 4 weeks, but at patient's insistence, didn't want to come back, but had a good outcome nonetheless. Now, case 3, very similar to what Andrew was showing just now with the large PED. So this is, again, a patient previously treated with PCV, very anti-VEGF hungry. So this is 6 monthly Aflibercept 2 milligram injections. And there you can see, although there's a resolution of that subretinal fluid, you still have that large PED. So there are PEDs and there are PEDs, and in a case like this with an active polyp, I would still be quite worried that this disease is still active. And I would still try to persist with treatment. Again, at which point I got my hands on some 8 milligram. Interesting story about this patient. This was my first patient I treated with 8 milligram. And when he came, I said to him, look, if you've got a new drug, but you have to promise me at every visit, you get an ICG. And so he said, yes, I will have an ICG every visit with the new drug. So at which point I switched him to 8 milligram, and there you can see rapid improvement of that PED. That's his ICG. Polyp is still present. There's a little bit of this subretinal fluid, and we could argue about this or discuss. But is that really subretinal fluid, or is that some space after that PED has resolved? Again, I treat him after 8 milligram. You can see some of that fluid going away. Polypoidal lesion still persistent. After the third Aflibercept, you can see again that PED really coming down nicely, and that polyp lesion actually getting better. So you're having that resolution, that getting smaller of that polypoidal lesion. Patient went on to have his 4th monthly Aflibercept 8 milligram, and there finally I think I've achieved polypoidal lesion closure. I'm not brave enough to extend him quickly, so he was stuck on about a 6 to 8 week interval at the moment. But you know, these are the patients perhaps that you would start with your experience with 8 milligram. You know, they are difficult to treat, so you may not get the same kind of results as what you get in the trials, but if you persist, things tend to get better. And this is some of the work we do in SNEC about 3D reconstruction of these polyps, and you can see that resolution of that polypoidal lesion itself after 4 injections.